This case presentation is of a 68-year-old male whose main complaint is low back pain radiating down to the left thigh and numbness to the upper part of the left foot, also complaining of outside foot numbness. Patient had an open MRI that showed L2, L3 large left disc extrusion with facet arthropathy and neuroforaminal narrowing. L3, L4 his, L4, L5 disc protrusion leftward. Initial part of the physical assessment consists of inspection and palpation. C7 should be the most prominent C-spine. Observe for any scars. Palpation of the spinal process can reveal localized tenderness seen in compression fractures, epidural tumors, or abscess. Patient was positive for Fabry's test bilaterally. As good providers, we must be able to differentiate that pain and that groin suggests hip joint pathology, whereas sacroiliac pain indicates dysfunction of the sacroiliac joint. Normal back extension is 30 degrees. Our patient had discomfort at 10 degrees. Pain provoked by back extension is suggestive of facet arthropathy. This correlates with our MRI of patient having an L2, L3 facet arthropathy. Normal forward flexion is 90 degrees. Our patient was asymptomatic upon doing this maneuver. A good pain provider will be able to differentiate that pain provoked by this forward flexion is consistent with ischogenic in nature due to the actual loading. Our patient was positive for pain with bilateral lateral flexion. When assessing a lower back patient, it's imperative to assess lateral flexion because facets of the L3 to S1 of the contralateral side undergo the most capsular strain compared to the ipsilateral side. For example, the left facet joints are most strained during right lateral flexion. In contrast, the L1, L2 to L2, L3 undergo greater capsular strain during ipsilateral flexion. Because our patient is complaining of back pain radiating to the front of the left thigh, I want to assess hamstring strength. I want to do this because I know that sartorius muscles is supplied by L2, L4. By asking our patient to pull toes up to the sky, the patient is engaging the extensor hallucis longus muscle. By doing this, we are assessing nerve root L5 via the deep peroneal nerve. By asking the patient to push down on the gas, the patient is engaging the gastrocnemius and soleus muscles. By doing this, we are assessing nerve root S1, S2 via the tibial nerve. If patient has pathology in this nerve root, weakness or pain could be appreciated. Knee flexion engages the semitendinous and semimembranous and bicephemoris muscles, which are innervated by nerve root L5S1. In this case, patient had 5 out of 5 strength bilaterally, meaning full power against resistance. By asking our patient to pigeon toe walk, he is engaging the tibialis posterior muscle. This muscle is innervated by nerve root L5S1 via the tibial nerve. If pathology is in this nerve root, weakness or pain could be appreciated. Pinprick and temperature are mediated by the alpha, delta, and C small fibers and are transmitted in the spinal cord by the lateral spinothalamic tract. In our case presentation, our patient had dim sensory to the left leg during pinprick assessment. Because in our case presentation, I am suspecting nerve root pathology, we are assessing in a diamathermal pattern, L5 nerve root being shown. When peripheral neuropathy is suspected, a distal to proximal pattern of testing is recommended. Deep tendon reflexes are mediated by the monosynaptic arc. Patellar reflexes assesses L4 nerve root. Quadriceps femoral reflexes assesses L3, L4 nerve root. Achilles reflex assesses S1 nerve root. In my case presentation, our patient had grade 0 Achilles bilaterally. Upon completion of physical assessment and study of films, the patient was diagnosed with lumbar back pain, left radiculopathy at L2, L3, and left radiculopathy at L3, L4. ICDs for this pathology are as noted. Because patient had failed conservative treatment, he was a candidate for a lower epidural steroid injection at L2 at L3. He was discharged home on the same day with a pain journal to be kept over the next 2 weeks to be assessed at follow-up. If patient had not gotten acceptable pain relief, second plan was to perform a transforaminal, which is a more selected nerve root